All right, today we are diving headfirst into some real-life clinical detective work. We're breaking down the locomotor examination. That's the systematic way clinicians figure out exactly what's going on with our muscles, bones, and joints. So, how do they even begin to crack the case? Well, it all starts with a pretty fundamental question.
And really, this is what it's all about, isn't it? A great physical exam isn't just about running through a checklist. No, it's a full-on investigation. It's about spotting all the subtle clues your body leaves behind. A slight limp, a little wince of pain, a joint that just doesn't move the way it's supposed to. All these little pieces help solve a physical puzzle.
So here's our game plan. First, we'll look at the universal blueprint that every clinician follows. Then, we'll get into how something as simple as your walk can tell a whole story. After that, we'll cover the hands-on part of the exam, see how special tests help zero in on a diagnosis, and finally, how all those clues get pieced together for the final verdict.
Every great detective has a reliable method, a system, and in the clinic, that's this universal framework. It's designed to make sure nothing, and I mean nothing, gets overlooked. This right here? This is the master plan, the playbook. It all starts with proper exposure and positioning so you can actually see the area you're looking at. Then, the investigation follows this classic, logical sequence. First, you just look. Are there any visual clues like swelling or redness? Next, you feel the area. That's called palpation, checking for tenderness or warmth. Then, you see how it can move, assessing its range of motion. But we don't stop there. Special tests are brought in to provoke specific parts. And finally, a super important neurovascular check makes sure the nerves and blood supply are all working properly. This 6-step process, it's the foundation for literally everything that follows.
So with that framework in our back pocket, the investigation often kicks off before the patient even makes it to the exam table. Seriously, the second they walk into the room, their gait, the way they walk, can give away some of the most revealing initial clues.
A normal walk is this beautiful, complex rhythm, and it's basically split into two main parts. You've got the stance phase, that's about 60% of the cycle, when your foot is on the ground, taking your weight. And then there's the swing phase, the other 40%, which is when that same foot is up in the air, swinging forward. This balance, this 60-40 split, is our baseline for what's considered normal.
Okay, now here's where it gets really cool. When that normal rhythm is off, it can point directly to specific problems. An antalgic gait, that's just a fancy word for a painful gait, means someone spends less time on their sore leg. Makes sense, right? You want to get off it quickly. A Trendelenburg gait, where you see one side of the pelvis drop with each step, that's a huge red flag that the hip muscles on the opposite side are too weak. And a high-stepping gait? Well, that might signal a nerve issue that's causing foot drop, so the person has to lift their leg way up high just so they don't trip. Each of these little deviations is a major clue, pointing the detective right where they need to look next.
All right, so after observing the walk, it's time to get some more direct evidence. This is the hands-on part of the investigation. Look, feel, and move. So during the feel stage, or palpation, a clinician is checking for things like temperature and swelling, but they're also kind of listening with their hands, feeling for something called crepitus. That's a grinding or crackling sensation in a joint. And the details here are fascinating. A fine crackling might suggest inflammation in the joint lining, but a coarse, gritty grinding sound that often points to much more significant cartilage damage, like you'd see in osteoarthritis. The very texture of the feeling becomes a clue in itself.
Next up is move. We have to know how much a joint can actually move. We check this two ways. When the patient moves it themselves, that's active motion, and when the clinician moves it for them, which is passive motion. And you know what? The difference between those two can tell us whether the problem is muscle weakness or some kind of physical blockage in the joint itself. As you can see here, every joint has an expected normal range. A little tool called a goniometer is used to get a precise measurement, which turns a subjective complaint like, "It feels stiff," into a hard number. That number is crucial for tracking a patient's limitations and progress.
So once the general area of suspicion is narrowed down, it's time to zero in on the specific culprit. And this is where special tests come into play. These are cleverly designed to isolate and stress a single ligament, tendon, or nerve to see if doing so reproduces the patient's symptoms. These tests are basically highly specific diagnostic moves. For example, if you suspect an ACL tear in the knee, you do the Lachman's test, which gently pulls the shin bone forward to check for too much wiggle. Or, for a suspected Achilles tendon rupture, you've got the Thompson's test. The clinician squeezes the calf muscle. If the foot doesn't automatically point downwards like it should, that's a positive test and a very strong sign of a rupture. These tests can provide those aha or gotcha moments in an examination.
And of course, the neuroassessment is just as critical. Part of that involves testing muscle power, which gets graded on this standard 0 to 5 scale. A grade of 5 is totally normal strength. A 3 means you can lift your arm against gravity, but you can't fight back against any extra push. And a 0, well, that means no contraction at all. It's a simple but incredibly powerful way to objectively measure how well the nerves and muscles are communicating. Okay, so we've gathered all of these clues from the way the person walks, from what we can feel, from their range of motion, and from all those special tests. The final, crucial step is to put it all together and see what story it tells. It's time to form a coherent diagnosis.
This is where pattern recognition is absolutely everything. One of the most fundamental questions a clinician has to answer is whether they're looking at an inflammatory disease or a mechanical one. And as you can see here, the clues point in totally different directions. Inflammatory problems like rheumatoid arthritis tend to cause long-lasting morning stiffness that actually gets better with activity. On the flip side, mechanical problems like osteoarthritis usually feel better after some rest and get worse with activity. Putting these patterns together is the real art and science of diagnostics.
And in the end, the whole investigation isn't just about sticking a label on the problem. The goal isn't simply to name the disease. It's to understand how it's actually impacting a person's life. It's about documenting the findings, sure, but also about framing it in terms of function, their ability to walk, to work, to get dressed in the morning. That's what truly matters. It's about solving the case for the person, not just for their medical chart.
So the physical exam is this incredibly powerful tool that gives us all the essential clues. But what happens next? Well, solving the case for good often means taking these findings and combining them with other evidence, like imaging or lab tests, and, most importantly, with the patient's own story. That's how you build a complete picture and ultimately find the best path forward.